Thank you, Aoife, and thanks for the organizers for inviting me. Transplantation in CLL used to be a very clear-cut decision until recently, because we had these high-risk criteria at hand, which were drafted now 10 years ago, with some of our current panel members being heavily involved in this. And there were three criteria, which was, the first was complete and true fludarabine refractoriness. The second was, at that time, it was more speculative than anything else. That was the early relapse after an intensive pretreatment defined as fludarabine-based combination therapy. And just recently, it took 10 years to verify that this indeed is high risk. Now we have the first peer-reviewed publication on that, recently published by the MD Anderson group. And here you can see in yellow those patients who have relapsed after FCR within the first 3 years, not 2 years. Anyway, the overall survival after a new need for treatment, after relapse, after FCR, is indeed detrimental, with about 2 years overall survival of these patients. And those who are relapsing within 1 year are even worse, so the truly FCR refractory patients. There was a few patients with a long survival after relapse after FCR, and most of them, as illustrated here by this red balloon, are those who underwent a consolidating allotransplant. The third EBMT criterion defining high-risk CLL was what we called at that time P53 mutation. That was more or less synonymous to 17p deletion, and only recently we learned that TP53 mutation indeed confers a similarly bad prognosis as 17p- does. And here we have a German-French study, the CLL-20 trial, investigating alemtuzumab plus dexamethasone as first-line treatment for 17p- patients. And you can see, and this at the same time represents the best results we can achieve with conventional or old-school treatment in this otherwise high-risk group, where the progression-free survival of these 42 or something patients was around 3 years, and the overall survival was better compared to those patients who had 17p- deletion and were relapse refractory, where we had only 1 year progression-free survival and 2 years or so overall survival. And this was also achieved because it was free to the patients to proceed to a consolidating allotransplant approach in this study. And you can see indeed here was a significant benefit, now more or less transforming into a plateau of those patients who were able or managed to proceed to allogeneic transplantation, with also a significant overall survival benefit, again highlighting that indeed transplant for these high-risk patients in the old days was the treatment of choice once they were eligible to undergo this procedure. And this is of course due to the graft versus leukemia effect, which is illustrated here in this single patient, where you can see that after the transplant, as indicated here by this narrow line, the MRD load goes down by 2 logs or so, but then it stays there until we were able to stop the immunosuppression. Some chronic graft versus host disease appeared, and in parallel with that, we saw the further decrease of the MRD load down below the threshold of detectability, and there it remained in this lady now for more than 10 years. And that was not only a single observation. In the prospective trial of the German study group, we were able to identify 42% of patients following exactly this pattern. In addition, there were some patients who became immediately MRD negative after the conditioning, and very few patients later on were able to be converted to MRD negativity by DLI or some other immune intervention, whereas 40% had a so-called other pattern, which means they were not able to become MRD negative. If we do then with these patients a landmark analysis looking at those who are MRD negative at 1 year after transplant, you can see that those who manage to be MRD negative have a much better disease control in the long term than those who remain MRD positive. And that is not only in clinical terms, but also in the durability of MRD negativity, which is higher than 80% after 5 years. Nevertheless, a note of caution, there was one single patient who became MRD positive after 8 years and later on had a clinical relapse. And this very effective disease control conferred by GVL was present across all genetically defined risk groups, in particular those who are 17p minus or TP53 mutated. All these upward arrows indicate that these remain MRD negative at their most recent control. Again, data from the CLL3X trial. And this is the basis that we are able to observe in all of these prospective reduced intensity conditioning based studies in CLL, 40 to 50% 5-year progression-free survival and a little bit better overall survival between 50 and 65% or so. And those who are sitting in the front may see that all of these progression-free survival curves more or less end as a plateau. So this is the good side of transplant. The bad side, of course, is toxicity, in particular non-relapse mortality, which is, however, nowadays much lower than it used to be in the past. The so-called early death rate, which means non-relapse mortality within the first 3 months after transplant, is now below 5% in almost all of these studies, and that used to be around 30% in the old days. Nevertheless, we observe a 20 to 25% non-relapse mortality in long term, and this is due to the chronic graft-versus-host disease in particular, which is the price you have to pay in the transplant therapeutic concept. Nevertheless, despite of that, when we're doing a donor versus no donor comparison of patients who were referred to transplant evaluation to our hospital and were fulfilling the EBMT risk criteria so that we were starting donor search, those patients who had a donor found within the first 3 months had a much better overall survival than those where we didn't found a donor, independent if they were indeed transplanted or not. So 25% of these were not transplanted and had a very detrimental survival. So this, I think, highlights that there is some benefit, and at any time survival was better in the patients with a donor than compared to those without a donor. That means that even taking into account the non-relapse mortality, these patients have a better survival at any time. Nevertheless, if we now look at the EBMT data, we see a very nice increase of the allo numbers up to the year 2011, and then afterwards we see a moderate decline, whereas in the auto setting, by the way, there's almost nobody now undergoing autografting for CLL. That means, however, that CLL is no longer the top number one allo indication within the lymphoma subset in the EBMT registry. Indeed, the decline in the CLL was biggest within the last 2 years. This is the allo numbers. We disregard the auto numbers for the current purposes. And this, of course, is due to the advent of the new drugs. You have heard a lot of them already this morning, so I may proceed to this question. Should we put now allografting into the museum in CLL and just look forward to the new options? I don't think we will end up with this radical conclusion. but it seems that we have to amend the high-risk criteria we defined 10 years ago. And I will start with the 17p- but treatment-naive patients. And here you have again some curves you have seen at least in part already today. So these are the best results we were able to achieve with 17p- treatment-naive patients before the advent of the new drugs. Just remember, progression-free survival in this trial at 3 years. And now looking at treatment-naive patients with the new drugs and 17p- being present, you see that this is clearly untoppable. This is rituximab idelalisib. However, these are only 9 patients, and the follow-up is not really tremendous. So let's wait what happens here. But also with ibrutinib monotherapy in patients who are treatment naive and have 17p-. This is data from the Wiesner group, just recently published in Lancet Oncology. You can see that with a median follow-up of 2 years, there's only 2 progression events, and that seems to be clearly better than what was possible in the old days. So the bottom line is that it seems that disease control under the new drugs is extremely promising for 17p- patients treatment naive. And these patients also now for the first time have a reasonable salvage option, which was not the case in the past, if they relapse after a first-line chemoimmunotherapy or even, but this is not clear, after a first-line targeting drug regimen. And for these reasons, we think that the rationale for transplant in first remission in these patients has become faint. Coming to the relapse refractory patients fulfilling high-risk criteria with or without 17p-, again, these are the left curves, the worst curves in the CLL-2 trial. And here, just for comparison, this is the study with the longest follow-up of the targeted drugs, the John Bird study published in the New England Journal that was recently updated at the ASCO meeting. And you can see that in green here, the 17p- fraction of this 100% sample has a continuous decrease and ends up now at the 30-month follow-up at around 50%, and the overall survival is closely following that. And just recently, we had the 3-year follow-up of this study published in Blood, and these curves, of course, are not very similar. The only additional notion is that for some reason, the 11q- patients in this study also, in the end, are dropping down. So let's wait what that means. This is idelalisib monotherapy, the pilot study published in Blood at the beginning of last year. And the curves look a little bit poorer, and they are extremely poor if the few patients who were 17p- are taken into account. And here the progression-free survival was only 5 months in this study. And this, have you seen, just to illustrate that with all of the new drugs, the overall progression-free survival at 1 year, this is ABT199, independent of the 17p- status, is 70%, which is excellent, but of course far away from highlighting or announcing cure. So it seems that the new drugs all show much better response rates and disease control rates than reported for any chemoimmunotherapy, including those patients who are 17p- and have relapsed refractory disease. But in particular, this subset seems to retain poor prognostic impact with any of these new agents. So nevertheless, it seems that this red curve has the potential to significantly climb up with the new drugs, although and this is a recent paper again from MD Anderson, those patients who are progressing or have to discontinue ibrutinib, this is just ibrutinib, all the MD Anderson patients who had received ibrutinib and for some reasons had to discontinue, you can see that the overall survival is really extremely poor with 3 months after discontinuation of this in this group. Now I make a little joke here, just projecting survival curves of different studies together. This is ibrutinib, what you have seen, the 1102 trial by John Bird and Susan O'Brien. This is the green one. This is all overall survival. The red one is the idelalisib approval trial. These blue ones are the Heidelberg transplant patients fulfilling high-risk criteria, of course. And you can see that during the first 2.5 years, the overall survival is more or less superimposable. And we know what happens after with the transplant patients. So the curves are now transforms into a type of plateau, still some events later on. But we don't know what will happen here. But it's very unlikely that these curves will end up here. So I think we see some arguments for still recommending for certain patients the transplant option. Another thing which has to be taken into account is that the new drugs can also be working in concert with transplant, and we have now the first data on patients who receive ibrutinib after transplant. This is data from Heidelberg again, and this is the overall survival of those patients who relapse after having undergone allogeneic stem cell transplantation for CLL. There are a few patients which can be durably rescued and put into MRD negative remission by DLI and some immune modulation. But you see there are a lot of other survivors, and most of these now receive or are on ibrutinib, and it seems that this is well tolerated and highly effective. And I will present you some more data on that. This is off record, so to say. This is in press with the JCO data from the MD Anderson again, asking the same question. The blue curve here are patients with CLL who relapsed after transplant. You can see that here the median overall survival, more or less similar, a little bit better than in Heidelberg, was 3 years. So it does not mean that if you relapse after a transplant, you're immediately dead. And this has a good perspective. Also here, ibrutinib was given to 5 patients, so we assume that we see some benefit here. At the recent ASH meeting, there were 2 studies, small studies, looking at those patients who have ibrutinib, who have received ibrutinib within the approval trials or within the first trials and had been transplanted before. Altogether, there were 16 patients in this abstract here, and these patients received ibrutinib at a median time of 2.5 years after transplant. There was a big number of 17p- patients. However, the 2-year progression-free survival was 77%, which is more or less similar to what you see, or maybe even better to what you see in untransplanted patients under ibrutinib. And there were no additional adverse event patterns. In particular, there was no evidence that ibrutinib could induce any graft-versus-host disease. And this is a slide given to me by Dave Miklas from Stanford. They had a closer look to their patients who received ibrutinib after transplant for relapse. And in this particular case, there was a quite desperate situation. Despite chronic graft-versus-host disease, the disease was more or less uncontrolled until they came in with the ibrutinib. And under ibrutinib, you can see that the CLL load disappeared, and this patient actually became MRD negative. And for some toxic reasons, they had to discontinue ibrutinib. And at the time of the ASH, this patient was 8 months off ibrutinib and still being MRD negative. So there might be some synergy between ibrutinib and the GVL potential of transplant, which may result in optimum results. And the other side of the coin of ibrutinib in particular is that it also might interfere with the graft-versus-host disease. There is some preclinical data published showing that animals receiving ibrutinib have a lower risk of getting chronic graft-versus-host disease than those who are receiving placebo. That might be due to the fact that ibrutinib also targets some kinases in T cells, which could be an explanation for this observation, which has resulted now in starting a trial of using ibrutinib for treatment of chronic graft-versus-host disease in the US. So there may be a chance that the archaic treatment of transplant may work well together with a targeted treatment we have now at hand, and that to figure out that better, the EBMT is now doing a non-interventional and observational study trying to collect two types of data. The first type is collecting the transplant outcome data of those patients who have received ibrutinib before transplant, and eligible are patients with mantle cell lymphoma and CLL within the approved indications for ibrutinib in Europe, and we hope to collect 50 patients by the end of July 2017. And the second, more rapid part of this study is collecting data on those patients who receive ibrutinib after transplant, again in mantle cell lymphoma and CLL. The primary endpoint here will be non-relapse mortality, and this probably we will be ending a year earlier because these patients are already existing in bigger numbers. So the bottom line is that there is some reason to believe that not only the non-transplant strategies but also the transplant results will improve with the new drugs available. And that brings me to the preliminary conclusion that I believe that novel drugs will improve the outcome of high-risk relapse refractory CLL substantially but not satisfactory. And of course, these drugs might have the potential to improve the outcome of transplant in high-risk CLL as well. So what to do? We have the targeted drugs. They have, of course, less non-relapse mortality, less graft-versus-host associated or no morbidity. They are highly efficacious, but they are not curative. It's unclear what we can do once we see a relapse or progression under a new drug. They are limited efficacy in 17p- patients, and they are expensive, more expensive than a transplant within 1 year. The transplant has the advantage of curing patients. It is similarly effective in 17p- patients, and I have shown to you that we are able to salvage these patients once they relapse quite effectively. Of course, we have the considerable non-relapse mortality over the years, and we have the age, comorbidity, and donor restrictions. So what to do in the year 2015? We don't know for sure, but you might have seen that the EBMT and the ERIC has published recently some kind of hints how to deal with these patients. So we think that all patients with high-risk relapse refractory CLL should receive one of the new drugs. Those who do not respond might receive another new drug but should be seriously considered for transplant. Those who do respond, there we have two options. Of course, one is transplant and the other is continuing the new drug. This might be particularly appropriate in those patients who have a lower disease risk, meaning that they are not having 17p-, and of course, if they are treatment naive, or they have a higher transplant risk, meaning they are at higher age, they have significant comorbidity, or they have not a well-matched donor. The other way around, those who have a higher risk, meaning 17p- and perhaps 11q-, and having a low transplant risk, being not too old, having no comorbidity, have a very good donor, these are factors which might favor transplant. However, the last decision has to be taken by the patient himself. Having said that, I can summarize that high-risk CLL definition needs to be refined. It could be in the new era the 17p minus relapse refractory patients and obviously those patients who are relapse refractory and are not responding to one of the new drugs. A transplant indication needs to be individualized, considering disease risk and transplant risk and the patient's preferences. But nevertheless, transplant remains the most effective tool, at least in GVL-sensitive patients with high-risk CLL. And finally, I would like to thank Aoife and Bertrand for inviting me and all the co-workers who helped putting these data together, in particular Emily and also Aoife, who were very supportive, not only in putting together the EBMT and ERIC consensus papers. Thank you.